Hi there, I'm Chris Lundeen. I'm going to be giving the lecture on the thoracolumbar spine review. Please excuse as I kind of look away off the camera every once in a while as I'm going to follow along with the slides on my own computer. Neil Dilworth has been kind enough to ask me to give this talk, and so I'll try to go through it as efficiently as possible and review the slides as we're going along. I'm an orthopedic surgeon down in Melbourne. I trained in Calgary and then ended up moving down here to Melbourne because my wife is Australian, doesn't like cold winters. I do spine surgery at the Royal Children's Hospital and the Austin Hospital in Melbourne. So today we're going to focus on thoracolumbar spine pathologies in children, adolescents, young adults, and then the elderly. In terms of disclosures, I have no financial disclosures and no financial relationships with any implant companies. Important points for this talk: that this is a review. I'm going to try and cover a whole bunch of stuff in a relatively short period of time. There are textbooks and conferences dedicated to each of these individual topics, so one slide on each topic is very much a brief summary, and I'm just going to try and cover some important aspects of each topic. Back pain is common. It's a massive topic. There is a huge differential diagnosis, and we're going to try and work through some of the salient features of different areas so that you hopefully pick up on different points and don't miss some of the major things that we have to look out for. The fourth slide is just a brief differential of things we're going to cover in this talk. It is by no means exhaustive. There are many other things, particularly non-musculoskeletal, that can present with back pain that you're going to have to work through on your history and physical exam with each individual patient. All right, getting right into it. Conditions of the child and adolescent. Things we're going to talk about are scoliosis, spondylolysis, spondylolisthesis, Scheuermann's kyphosis, and discitis. So first up, scoliosis. The most typical type of scoliosis that will present to you will be idiopathic scoliosis. It occurs in somewhere between 3 to 5% of the population. Around 90% of scoliosis will not require any treatment. That it's not going to progress to the point of requiring bracing or surgery or anything else. The curves will stay under about 20-25 degrees, and most patients do very well. However, 10% of patients will require or would be recommended to have medical intervention. Scoliosis is a rotational deformity of the spine that when you take an x-ray, it looks like a lateral bend to the spine. To have true scoliosis, you need at least a 10-degree curvature measured by the Cobb angle on a PA x-ray. One of the first things that I always highlight and want to point out that there has been a big leap forward in terms of x-ray technology. There's a new type of x-ray that you can take to look at the alignment of the spine called an EOS scan, EOS. It's much less radiation than a traditional x-ray. The machine itself is quite expensive. It costs about $1 million, so they're not everywhere yet. If you have access to an EOS scan, I would highly recommend using that for your patients because it is less radiation. It gives you better picture, a better idea of the global spine alignment, and very much worthwhile. In terms of idiopathic scoliosis, it, as the name suggests, we don't really know what the cause is. However, more and more research is coming out that it's primarily a genetic cause. We don't have any genetic tests yet that give us a good prognostic picture of the scoliosis, but there's lots of research going on behind the scenes with that. Imaging and workup for these patients needs to involve looking for things that suggest it might be something other than idiopathic scoliosis. So looking for neuromuscular disorders, congenital problems within the spine that may cause the scoliosis, or other syndromes that can cause scoliosis. So you have to rule out the other things before you can diagnose idiopathic scoliosis. The most common type of curve is a right thoracic curve and will present with a right thoracic prominence on forward bending called the Adams forward bend test. Things you need to look out for that may present similarly is a leg length discrepancy that can push one set of shoulders up compared to the other side. Then also looking for non-idiopathic etiologies for the scoliosis. Important things on physical exam, of course, you need to do a neurologic exam to make sure that they have no neurologic abnormalities, including looking for symmetric reflexes or pathologic reflexes. You also need to be assessing their shoulder heights, pelvic height, pelvic asymmetry, and then getting a forward bend test to see if they have any rotational deformity of the spine. Imaging, plain x-rays are going to be your mainstay. And as part of that, an assessment of how much growing does this patient have left. That patient with a great deal of growth potential left has a greater potential for the curve to progress. Patients that are skeletally mature are less likely to progress, other than what gravity will do to slowly pull on that spine. And we'll talk about that a little bit later in terms of the adult deformity. Management, patients with a growing spine who have significant growth remaining and have a curve between 25 and about 45 degrees are a good candidate for bracing. I recommend looking at the BRACE trial, which was published in New England Journal of Medicine in 2013, published by Weinstein, and it goes into detail about the benefits of bracing for scoliosis. If you see a curve, I recommend a referral to an orthopedic surgeon, particularly one that specializes in pediatric spine, as the key to these patients is getting early appropriate treatment when they're still growing to hopefully prevent progressive curves. Curves up over 50 degrees are when we usually start considering surgery, and that's a discussion between the patient, family, and the surgeon. That not all patients need to have surgery, but we know that larger curves do tend to progress more even after skeletal maturity because of the pull of gravity. On slide 7, you'll see an example of the forward bend test with the right rib prominence and an x-ray showing a primary right thoracic scoliosis. You'll also see a compensatory lumbar curve and a compensatory upper thoracic scoliosis. That this would be your prototypical patient. Menarchal status is important. Many of these patients, almost 10 to 1 female to male ratio in terms of adolescent idiopathic scoliosis. It's a bit different in the neonate and juvenile scoliosis. Tends to be a smaller ratio of females to males. But in this age group, very much more commonly in the female population. And menarche is a helpful status to give us an idea of growth potential. Most girls grow for about 2 years after the first period, and this gives us an idea of where they are in terms of growth cycle. Next topic is spondylolysis. Spondylolysis is a stress fracture of the pars interarticularis. It occurs in certain subgroups of the population. It's more common in Polynesian, Pacific Islander populations. It's also more common in the native North American population, particularly from the north, as well as certain groups of patients that come from certain activities. It is a stress fracture. Patients who have a greater degree of sporting activity, particularly hyperextension of the lumbar spine, seem to be predisposed to it. So common presentations in North America would be young gymnasts, gridiron players, particularly those guys playing on the line, and then certain activities as well, things like people who are extremely active with trampoline or high divers also have quite a high prevalence of spondylolysis. The main treatment for spondylolysis is going to be reducing stress to minimize the stress to the stress fracture. You'll note the stress fracture on a plain x-ray, ideally an oblique x-ray to look for the Scotty dog sign, looking for the pars interarticularis. It can also be picked up on a CT or bone scan. I usually recommend against CT or bone scan unless you really need it because of the high dose of radiation in a young patient, and the less we can irradiate their kind of lower lumbar spine and pelvic region, better for them. MRI can also be useful if they have radicular symptoms. It can also pick up edema changes in the region of the pars if you don't see a true fracture on x-ray. Like I mentioned, main management strategies are going to be activity modification, anti-inflammatory medications. Surgery is very, very rarely indicated. Getting this stress fracture to heal is extremely difficult, and surgery hasn't proven to be much more effective than non-surgical management. And most of the time, patients do quite well once the initial stress fracture settles down. On x-rays, you'll still pick up stress fracture for the rest of their life typically, but many patients do quite well. Occasionally, some into adulthood will get a bit of degeneration, and then potentially a spondylolisthesis later on in life. And that leads us on to spondylolisthesis. Sorry, I should say slide 9 shows an example of that pars interarticularis defect. Excuse me. Spondylolisthesis is a slippage forward of one vertebra over another. So spondylolysis is the stress fracture. Spondylolisthesis is the slippage. They can occur independently of each other. So spondylolysis can be one cause of spondylolisthesis, but you can have spondylolysis without spondylolisthesis, and you can have spondylolisthesis without spondylolysis. There are multiple causes of spondylolisthesis. There include spondylolysis. You can also have dysplastic posterior elements that can cause the slippage forward. Iatrogenic can be caused through a surgery, can happen through trauma or tumors. And reading up a little bit more about spondylolisthesis would definitely be worthwhile. Most commonly occurs in the lower lumbar spine. It's certainly not isolated to the pediatric population, that it is quite common. We typically grade it based on how far one vertebra slips forward on the other, and we break it down into 25% segments for grade 1 through 4, and then a complete slip forward is spondyloptosis. Low-grade spondylolisthesis would be considered a slip less than 50% of the lower vertebral body, and a high-grade slip would be a slip greater than 50%. In a pediatric population, low-grade slips rarely require surgery. High-grade slips much more frequently go on to have surgical intervention. The whole key with management of spondylolisthesis is management of back pain and spinal balance. And this is the first time we're going to mention spinal balance, and it will become a common theme that we are efficient when our head is centered over our pelvis and our femoral heads. We are inefficient in terms of function of our lower spine when we're out of balance. And maintaining that spinal balance is a key component. A good rule of thumb to think about is when you look at a lateral of the lumbar spine, you want L4 to the floor. That means the superior end plate of L floor should be parallel with the floor. And any condition that puts L4 out of balance may lead to problems further north, i.e. the head being out of balance with the pelvis. And many of the treatments that we do are looking to rebalance that lower lumbar spine to help balance the pelvis and decrease the stress on the musculature of the lower lumbar spine. Management for spondylolisthesis, like I was saying, is going to be minimization of activities that cause pain if they have a low-grade slip, core stability work, again, minimizing a lot of hyperextension type work. And if they have a high-grade slip, then assessing them of whether or not they may need surgical intervention if they have any radiculopathy or severe progressive back pain. Again, for low-grade slips, many of these can be managed conservatively by yourself. The high-grade slips, I would definitely recommend referral to a pediatric orthopedic surgeon. Slide 11 gives you that example of grading system from 0 to 5. And it also shows a couple x-rays. One is a high-grade dysplastic slip of L5 on S1 in the 16-year-old female, and that patient is very likely to present with very tight hamstrings, radiculopathy, a palpable step in their lower spine, and that patient has a high risk of requiring surgical intervention to help rebalance their spine. On the right-hand side is a different scenario. That's a degenerative L4-5 slip with spondylolysis at L4, and that patient presents later on in life as they start to get some early degenerative changes and start to get some radicular pain, disc height collapse, and again, they've managed for over 40 years, but now they're becoming more symptomatic, and we'll try things such as corticosteroid injections, epidural steroid injections, and then eventually potentially a posterior fusion and realignment of that lumbar segment. Slide 12, Scheuermann's kyphosis. So Scheuermann's kyphosis is something that's often overdiagnosed, and to truly have Scheuermann's kyphosis, you need a thoracic hyperkyphosis. So that's measured between T5 and T12 of over 40 degrees. Of course, your overall kyphosis is typically more than 40 degrees, but it's difficult to measure above T5 on a typical x-ray because the shoulder starts to get in the way of measuring the vertebral end plates. So you're looking for a hyperkyphotic patient with at least 3 segments in a row of wedging of the vertebrae. If you don't have those requirements, you don't truly have Scheuermann's kyphosis. Some people talk about Scheuermann's disease and end plate changes. That's a bit difficult because there's many patients that have end plate changes on an MRI or an X-ray that are completely asymptomatic, and it's not necessarily overly predictive of patients that will or will not have pain. The exact etiology of Scheuermann's kyphosis is a bit unclear. The younger the patient that presents with it, we do have to watch for potential progression, and they may be a candidate for bracing as well. You do want to look for associated scoliosis along with this. Again, you'll be looking at a forward bend test to assess it, but instead of looking from the patient from behind, you look at them from the side to see how flexible or inflexible that kyphosis is in the thoracic spine or thoracolumbar spine, depending on where it is in each individual patient. The key, again, is getting upright x-rays and looking at the alignment of the spine. Many of these patients will be managed very nicely with some physiotherapy, some stretching exercises, and will not require surgery. There's no clear numbers to exactly when surgery is indicated. It's the more symptomatic patients, and typically when we're getting curves up over, tends to be over 75 and even 90, 100 and more degrees, that it's quite variable. Some patients with an 80-degree curve are quite asymptomatic and do quite well. Some patients with a 75-degree curve are in misery. Patients seem to be more symptomatic when they have more disease in the lower lumbar or thoracolumbar junction. It seems to be more symptomatic. The slide 13 just gives an example of that forward bend test where you see that posterior thoracic gibbus and an x-ray showing a patient with a hyperkyphotic thoracic spine, and they're out of balance. The head is pushed forward, and treatment would be to try to maintain flexibility of their spine and bring them back into balance. A little bit of a change up from the balance and spinal deformity stuff will be discitis. Discitis is something that can present really in any age group and typically presents in sometimes the very young and then the adolescents. Discitis in the very young is often very difficult to diagnose. In a 3 or 4-year-old, they're just going to be an irritable child that may or may not have any constitutional symptoms such as fevers, feeling unwell, lack of appetite. This might just be a kid that doesn't seem to want to play very well, maybe a bit of a limp, and will be important to assess for any other potential septic arthritis, like a hip septic arthritis or a knee septic arthritis, or it could just be a kid that seems to have the flu. They won't necessarily have any localizing symptoms to the lumbar spine because they might not say that that's where it hurts. Overall, research has shown that most of these do seem to be bacterial in nature. The young child, by the time we find out it's bacterial, sometimes the symptoms have completely resolved and they don't necessarily need antibiotics. Early x-rays, early imaging will likely show a completely normal lumbar spine. You don't really start to see changes for at least 3 to 4 weeks. You start to see some loss of that lumbar lordosis, flattening as they get a bit of spasm in the paraspinal muscles. And then you might see some disc height loss. In the older child, the 8-year-old, 10-year-old, 12-year-old, symptoms are persisting a little bit longer. They might have a fever. They might present to hospital with abnormal white cell count or an elevated ESR-CRP. You might do blood cultures as well. They're the one that would likely benefit more from antibiotics. They're going to present as, not necessarily in marked sepsis, but in a more of a sick child that likely will localize to their back. Again, early x-rays may be completely normal. You could do a bone scan, but again, I'd recommend against it for the simple reason it's a whole bunch of radiation that's not really going to change much of what you do. If you really think you need further imaging, again, I would recommend more of an MRI that will be able to pick up a bit more detail. It's no radiation. I know accessing an MRI is sometimes difficult, but in this type of a situation, it will definitely be more helpful and it'll be less harmful to the child. If you do diagnose a vertebral osteomyelitis or bacterial discitis in this older age group, then a course of antibiotics, probably 4 to 6 weeks, would be beneficial. The nice part is in this population, the overall prognosis is very good. Most of these patients do very well. The young child that often requires no treatment other than maybe some pain medications for a few days will do very well, many times without antibiotics. And the older child with a moderate course of antibiotics will again do very well. When you start getting into the adult population, discitis and vertebral osteomyelitis usually presents in the immunocompromised patient. And whether that is immunocompromised from IV drug abuse and malnutrition, or the cancer patient who's on chemotherapy and immunocompromised for that reason, in that scenario, you have to assess whether or not there's any evidence of an epidural abscess. If they do have an epidural abscess and have neurologic findings, then that abscess is going to need to be decompressed. If they have purely just septic arthritis, or sorry, not septic arthritis, but the discitis and vertebral osteomyelitis, then the mainstay of treatment would be antibiotic therapy. In slide 15, I've just shown a set of x-rays in a patient that I managed with low back pain and vertebral osteomyelitis and discitis. The initial x-rays at about 3 weeks of symptoms were relatively normal, maybe a bit of loss of the lumbar lordosis. And then you start to see that loss of disc height at T12L1 later on in the disease course. And he did undergo an MRI and also was treated with antibiotics for 6 weeks and did very well.